بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا كريم. Dear colleagues, now we will discuss the second part of the pediatric gastrointestinal imaging, and we have finished in the first part with the lesions of the esophagus, and also we discussed gastric abnormalities. Now we'll continue with the small and large bowel diseases. The small bowel is examined by what's known as the barium meal follow-through. To do this examination, we give the child a barium fluid in, until we can feel somewhat the stomach, and starting to image the stomach in different positions to show if there is any gastric abnormality. After we finish with the stomach, we give the patient another dose of barium fluid, and then we start to have regular or sequential films for the small bowel, demonstrating the flow of barium through the different parts of the small intestine, including the jejunum and ileal loops, until we reach the region of the ileocecal junction. Then the examination is considered finished. Then this is very important issue in the examination, that is, the terminal ileum and cecum should be demonstrated in the exam, because many of the abnormalities are located in this particular area. So we do not consider the barium meal follow-through examination is complete unless we can show clearly the region of the terminal ileum as well as the cecum. Then here you can see the barium has reached the colon, but the cecum, which is indicated by this letter C, is masked by the overlapping some of the small bowel loops. Then we have many of the techniques, including compression and apply some of the pressure to separate the loops, so that we are able to see the terminal ileum as well as the cecum in a clear image, as you can see here. Now, what are the lesions we would like to discuss? First, we'd like to discuss the issue of malrotation of the bowel, then the atresia, including duodenal, jejunal, and ileal atresia, then the small bowel volvulus, and meconium ileus and meconium peritonitis. If you give barium to the child and the barium has passed the stomach into the duodenum, then to the jejunum, the duodenojejunal junction is identified by this arrow, where a known ligament, which is known as the ligament of Threads, is located here. One of the important issues is to know that this junction between the jejunum, the duodenum, and the jejunum is located to the left of the spine. And you know that the duodenal lobe is formed of 4 parts: the first, the second, the third, and the fourth part. Then you can see after that the jejunal lobes. And whenever you have a barium meal follow-through, then you can identify that most of the duodenal as well as the jejunal lobes are to the left, are to the right of the spine. Then this is known as malrotation of the bowel. This may be absolutely asymptomatic and does not cause any troubles to the child, but it is a feature that can be commented upon on the barium study. This is the normal appearance. You see the duodenum, and you see the site of the ligament of Threads is to the left of the spine, as you can see here, and these are the rest of the jejunal and ileal loops. This is an example of malrotation of the bowel, and you see the duodenum and the proximal jejunal lobes in the early film, and later on they are also located to the right of the spine. This is an indication of malrotation of the bowel. This is the normal appearance. The stomach, the duodenum, and the duodenojejunal junction is to the left of the spine. Then duodenal atresia, meaning that the distal part of the duodenum is atretic. Then you can see air in the stomach and air in the proximal part of the duodenum, and this is known as the double bubble sign. You remember in pyloric atresia you see a single bubble sign in the stomach. In duodenal atresia you see double bubbles, one bubble in the stomach and the second one is in the proximal part of the duodenum. This is a characteristic appearance where you can see the big bubble in the stomach and the smaller bubble in the proximal part of the duodenum, and with no gas after that in the remaining part of the abdomen. And this is the classic appearance of double bubble sign, indicating the presence of duodenal atresia. Sometimes you may give barium to confirm the diagnosis. From the plain film you see the double bubble sign, and by barium, this is the nasogastric tube. You see barium in the stomach and barium in the dilated proximal part of the duodenum. This is also a classic example of duodenal atresia. The stomach is dilated and the proximal part is dilated, and there is absolute obstruction here. Another example of duodenal atresia, double bubble sign in the plain film, and after administration of barium, you can see barium in the dilated stomach as well as in the proximal part of the duodenum. Then after surgery, and to correct this abnormality, then you can identify the presence of air in the distal small bowel. Duodenal stenosis is a mild degree of duodenal atresia where you can see some barium passing this site of obstruction into the collapse in the distal part of the duodenum, and this is maybe analogous to this appearance, which is known as the windsock appearance, where you can see that barium trickling into the distal part of the duodenum is similar to this one. Then if the atresia is more distal than the duodenum, meaning in the jejunum, then you may get more than two bubbles filled with air in the abdomen. And one of the criteria is the three bubble sign. The three bubble or the triple bubble sign indicates high jejunal atresia. And this means that the stomach and duodenum and the proximal part of the jejunum are dilated, containing air. Then the triple bubble sign or the three bubble sign means that there is high small bowel obstruction in the proximal jejunal lobes. Three bubbles are seen in the stomach, in the duodenum, and in the proximal jejunal lobe. If you give barium, you can see that the stomach is dilated, the duodenum is dilated, the proximal jejunal lobe is also dilated. Now, if the obstruction is more distant, is in the area, this cannot be diagnosed by just the plain X-rays because there are many conditions that can cause this appearance. If any obstructive lesion is located in the terminal ileum or in the colon, it will result in distension of the abdomen by gases. And if you have the erect film, you can see multiple air fluid levels. Then one of the possibilities of distended bowel lobes containing air in the supine film and air fluid levels in the erect film is atresia of the ileum, or you mean that there is distal small bowel obstruction. And this is an example which is proved surgically, and you can see the dilated small bowel loops down to the level of the ileum. Then one of the possibilities here is the presence of ileal atresia, and this was confirmed by surgery. Dilated bowel loops with multiple air fluid levels, indicating that there is distal obstructive lesion. The initial radiograph showed distal small bowel obstruction, and the barium enema was performed to rule out microcolon. And this is one of the causes that can produce such an appearance is the presence of microcolon, as I will mention after that. Then the child symptomatically worsened over a period of time and was operated and confirmed to be atresia of the proximal ileum. Then in the background of this barium study, you can see dilated bowel loops filled with gases. This is the barium enema showing that the colon is small, and this is known as unused colon, or let us say microcolon, and this can be the sequelae of atresia of the bowel proximal to the colon, like atresia of the ileum, for example, and this was the case. If the ileum is atretic, then the bowel proximal to it will be dilated, and the bowel distal to it will be collapsed. And this is ileal atresia with small, let us say, microcolon, and this is because there is no food or residues came to the colon because of the atretic ileum. And atresia of the ileum, once more, will lead to dilatation of the bowel loops proximal to it and the collapse of the bowel loops distal to it. And then if you see a colon like this, which is usually termed unused colon, this is because of no residues came to the colon, either due to meconium ileus, which means obstruction of the distal ileum by inspissated meconium, or ileal atresia. And these are the two most common causes that can result in this small unused colon. Then we'll discuss meconium ileus later on. We came to the mesenteric volvulus, which means that there is torsion of the gut around the superior mesenteric artery due to a short mesenteric attachment. This can occur in neonates and young infants, and also can occur in older children as well as in adults. In neonatal period, it may be associated with duodenal atresia, duodenal diaphragm, duodenal stenosis, or even annular pancreas. And if you have the barium study, you have this very classic appearance, which is known as the corkscrew configuration of the proximal bowel. And you can compare the normal appearance of the duodenum and the proximal jejunum with this classic appearance of corkscrew, which indicates the presence of mesenteric volvulus or mid-gut volvulus. The patient will present by bile stain vomiting, abdominal pain and distension, and failure to thrive. Then normally in the CT scan of the abdomen, you see this is the head of the pancreas, and this is the common bile duct, and these are the two mesenteric vessels. The artery is the smaller one, and the vein is the bigger one. Then whenever you see that the superior mesenteric vein is to the right side of the superior mesenteric artery, as you can see here, and this is the normal appearance of the vessels at the root of the mesentery. In cases of volvulus, the position will be changed, and you got some whorly appearance here, which is characteristic of mesenteric volvulus, and sometimes it is referred to as the Barber Pole sign. This is the Barber Pole sign, and you can see it here. This is the normal appearance between the superior mesenteric artery and vein. This is the pancreatic head. This is the common bile duct. And in case of volvulus, and you see whorly appearance at the root of the mesentery. You cannot even identify the superior mesenteric artery or the vein, and also you got intestinal obstructive changes. This is a well-known configuration in patients with mid-gut volvulus or mesenteric volvulus, which is known as the corkscrew appearance of the proximal small bowel loops. And this is another appearance of mid-gut volvulus with corkscrew configuration, and this is considered a surgical emergency in order to prevent gangrene of the bowel. Then we came to the meconium ileus, which means that there is an speciated meconium lodged in the narrowest part of the gastrointestinal tract, which is the terminal ileum. And this will result in obstruction of the terminal ileum, meaning that the colon will be small and the proximal bowel will be dilated, containing a lot of gases. And you remember, ileal atresia and meconium ileus can result in the same appearance on X-rays and barium studies. The colon is small, unused, and the proximal bowel is dilated and filled with air. This meconium ileus is intimately related to the disease known as cystic fibrosis or mucoviscidosis, which affects the mucous membranes, especially in the chest, and also it can patients with cystic fibrosis can be affected by meconium ileus. Then meconium ileus means that there is multiple and speciated meconium masses or pellets in the terminal ileum, resulting in distension of the proximal bowel and a small caliber of the colon, which is known as microcolon or unused colon. Then if you want to diagnose the patient with meconium ileus, and you inject barium in the colon until you reach the terminal ileum, and you can see multiple filling defects within the terminal ileum. And sometimes, in about 50% of the cases, barium enema will be curative as well. Whenever you push barium until reaching the terminal ileum, this may result in some liquefaction of the meconium, and will help in the clearance of meconium from the terminal ileum, and then you got cure of the patient. And this is meconium ileus, barium enema, and you see multiple filling defects in the ascending colon as well as in the terminal ileum. And by continuing injection of barium, you may got this appearance with some liquefaction of the meconium and the relief of the symptoms. Another case of meconium ileus, and you see the colon is collapsed, which is unused. You got meconium drop pellets in the terminal ileum and the proximal part of the colon. And this is the appearance of meconium when it is accumulated in the terminal ileum, and you can see the tenacious nature of this meconium, which is not easily excreted through the normal ways. Then by plain film, you cannot predict that you are dealing with a case of meconium ileus, but you can see distension of the small bowel, which may be the result of many conditions. And whenever you inject barium through the colon and you got multiple filling defects in the proximal part of the colon as well as in the distal part of the ileum, diagnostic of meconium ileus. And this is also another case of meconium ileus. The colon is small, and you see here multiple filling defects in the transverse and ascending colon, diagnostic of meconium ileus. And you look to the small bowel is distended by air. Then complications of meconium ileus include the 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 result of the intestinal volvulus or even intestinal perforation. Then perforation will lead to the meconium to be in the peritoneal cavity. This will result in some sort of calcification within the peritoneal cavity, and this appearance, whenever seen in a neonate, is almost diagnostic of meconium peritonitis. And whenever you see calcium within the peritoneum in a neonate, this is 2 days old, this means that there is some sort of perforation with meconium in the peritoneal cavity, leading to such calcification. It's important to know, and I would like you to look at this. The child did well without evidence of persistent perforation or obstruction, tolerated full feeds, and after appropriate observation was discharged home. Meaning that if you see a case with calcium calcification in the peritoneal cavity of a neonate, this means that he has some sort of perforation and meconium peritonitis, and this is not a surgical emergency. If the patient is doing well and tolerating the feeds, he can be managed conservatively without any need for surgical intervention. Then if you see calcium like a mass or like foci or something like this in a neonate, then you think thoroughly of the possibility of meconium peritonitis. Then we came to the acquired lesion of the small bowel. We would like to say something about pneumoperitoneum, recrutizing enterocolitis, small bowel intussusception, small bowel obstruction, and some of the inflammatory diseases like Crohn's disease and TB. And pneumoperitoneum means that you got a lot of air within the peritoneal cavity, and the causes may include: number one, necrotizing enterocolitis, which is considered the most common cause; perforated viscous, meconium ileus, and cystic fibrosis, Hirschsprung disease, intestinal atresia, or webs. Then the pneumoperitoneum may be iatrogenic due to introduction of tubes, mechanical ventilation, rectal thermometer, or even the enema examination. Then if you look here, and you can see that the abdomen is markedly distended by air surrounding the abdominal organs. One of the known signs of pneumoperitoneum is what is known as the copula sign. By the copula sign, you mean that usually you are not able to see the copula in contact with the cardiac shell. But if air is present, then you can see the copula of the diaphragm all through the whole abdomen from left to right. And this is known as the continuous copula sign, or even the copula sign, which is one of the criteria of pneumoperitoneum. You need to diagnose pneumoperitoneum to image the patient while he is erect. If not, then you can do this position, and you expose the patient from his lateral aspect, and then you can see air between the liver and the diaphragm, or between the anterior abdominal wall and the viscera. And sometimes the air is great within the abdomen, resulting in accumulation or displacement of the organs in the mid part of the abdomen, which is known as the football sign. And this is almost a configuration which you can simulate this type of the footballs. Then another sign of pneumoperitoneum is known as the regular sign. Regular sign means that you are able to see the wall of the bowel. Usually you are not able to see the wall of the bowel because air is only present inside the bowel. But If you are able to see the wall of the bowel, this means that there is air inside and air outside. This is known as the regular sign. And this red arrows point to the continuous copula sign, or the continuous diaphragm sign, or the dome sign. Then this is the regular sign. You are able to see the wall of the small bowel, and this cannot be seen unless there is air inside the bowel, which is normal, and air outside the bowel, which indicates pneumoperitoneum. Then we came to the necrotizing enterocolitis, where the underlying cause is not well known. It is suspected to be due to invasion of the intestinal mucosa by intestinal flora, secondary to ischemia, or decreased mucus production, or diminished immune response in a premature infant. And this will result in accumulation of a lot of gas in the wall of the small bowel, and this can be easily appreciated by ultrasound because gas locules are echogenic, and they may produce acoustic shadows like you can see here. But in the plain film, you are able to see this fine linear high radiolucent shadows which represent air in the wall of the small bowel, and many times you can also able to see air in the portal vein, and air in the portal vein is one of the bad signs that may indicate that this is a poor prognosis for the patient because of the associated necrosis and the ischemia of the small bowel. Then the symptoms of necrotizing enterocolitis are non-specific. They include feeding intolerance, vomiting, abdominal distension, and bloody stools. The diagnosis is easy from the plain film, and you see air in the wall of the small bowel. You may see air in the portal tracts. Barium enema or barium meal follow-through are contraindicated for fear of perforation of the necrotic bowel, and perforation will result in accumulation of the barium in the peritoneal cavity, and this is one of the bad issues. Then the pathognomonic finding of necrotizing enterocolitis is the presence of submucosal or subserosal air in the wall of the bowel. Abdominal free air usually requires emergency surgical intervention because this means that the bowel has been perforated. We came to the intussusception, which means that there is one segment of the bowel is pulled into itself or in a neighboring bowel loop. And the cause of this is not well appreciated in the pediatric age group in particular. In adults, the causes are usually secondary to tumor masses, but in the children, it is assumed to be hypertrophic lymphoid tissue secondary to infection. The majority occurs in children, in about 95% after the first 3 months of life. And the lead point of intussusception cannot be identified in many situations because of the absence of a demonstrable underlying cause. Clinically, the patient will present by intermittent abdominal pain because this intussusception may resolve spontaneously, then recur once more, and this will result in this intermittent abdominal pain. Vomiting, right upper quadrant mass, and you can see the mass of the intussusception, occult or gloss blood on rectal examination, and these findings are seen in less than 20% of the cases, and about 15% of the patients do not have symptoms. Then it is difficult to appreciate the presence of intussusception in the plain X-ray. But you can see some distension of the bowel, and you can also notice that the distal part of the pelvic region is devoid of gas shadows. But sometimes you are not able to predict that this appearance is due to the intussusception. And many times, if you inject barium, it's easy to diagnose this by this particular sign, which is known as the coiled spring appearance. And here, after introduction of barium in the colon, then you got the site of the intussusception, and you got some whirly-like appearance, which is an indication of intussusception. In this plain film, you are not, of course, able to diagnose that this is the site of intussusception, but because of the clinical symptoms in the patient are highly suggestive of intussusception, an abdominal ultrasound was performed and showed the classic appearance of intussusception, which is known as the target sign. Then if you go back to the plain film, you may assume or suspect that this is the probable site of intussusception. But ultrasound is a very good modality for diagnosis of intussusception. In the cross-sectional view, you got the target sign, and in the longitudinal view, and you got the loop which has telescoped into the adjacent loop. Then by plain film, you cannot predict the possibility of intussusception. You see dilated gas-filled bowel loops, but by ultrasound, you are sure from this target sign that you are dealing with an intussusception, and you can exactly locate its site. And this is an intussusception showing what is known as sandwich sign, with the telescope the bowel loop into the adjacent one, almost similar to this surgical appearance. This is the classic appearance of intussusception by CT, multiple whirly-like appearance or the target sign. Then we came to the intestinal obstruction, and by intestinal obstruction we got dilated bowel loops filled with gases, and if you have the erect film, and you got multiple air fluid levels, this means that you have an intestinal obstruction, and the causes are a lot, including intussusception, meconium ileus, surgical adhesions, ileal and colonic atresia, and Hirschsprung disease. But all what you can say from the plain film that in the supine position there are multiple dilated air-filled bowel loops, in the erect position and you got multiple air fluid levels. If you see a small bowel only, this means that you are dealing with a small bowel obstruction, usually in the distal ileum. But if you see also colon, as indicated by the hostra of the colon, then you know that the obstruction is distal in the colon. And here is another example of intestinal obstruction. The small bowel loops dilated, in the erect film you got multiple air fluid levels, diagnostic of distal small bowel obstruction. If you are not able to have an erect film for the child, and you can go for this lateral view while the child is in the supine position, and you got multiple air fluid levels as well, and this can be helped in the diagnosis. And Crohn's disease, as I have mentioned, can affect any part of the gastrointestinal tract, and I give example for Crohn's disease of the stomach, but I said that Crohn's disease most commonly affects the terminal ileum, and this is a granulomatous disease which results in mucosal ulcerations and some sort of fistulous tract with the adjacent bowel or with the urinary bladder, for example, and even the skin. If you have the CT scan, and you can see that there is marked thickening of the bowel loop encroaching on the bowel lumen, and this appearance is not specific for Crohn's disease, but can be seen in many of the small bowel diseases, and also can be seen in the colon in cases of ulcerative colitis, can be seen sometimes in cases of lymphoma, and this is not specific. The diagnosis is usually confirmed by mucosal biopsy. And one of the criteria of Crohn's disease in the terminal ileum is what is known as copulostone appearance. Then this copulostone appearance is the result of the disease causes damage to the mucosa and ulceration of the mucosa. Then the healthy mucosa will hypertrophy to compensate the function of the damaged mucosa, and this hypertrophied mucosal island will result in this cobblestone configuration. And ulcerative colitis is also one of the diseases that can affect the small bowel, but particularly it affects the colon, and this will lead to a very famous configuration known as the lead pipe configuration of the colon, meaning that the colon is narrowed and its wall is very smooth compared to the normal colon, where you can see the hostra of the colon everywhere, and this colon is transforming into something like this lead pipe. Then by CT you will see thickening of the wall, and you got narrowing of the lumen, and this is once more not specific for particular disease, and you need to the help of mucosal biopsy to confirm the diagnosis. One of the commonest sites of TB in the gastrointestinal tract is the terminal ileum and cecum. And I have said that the very main follow-through is not a complete exam unless you see the terminal ileum and the cecum. And here you see the terminal ileum is markedly narrowed with irregular wall, and also you see a marked narrowing of the ascending colon, and this is the criteria highly suggestive of ileocecal tuberculosis. The normal barium enema will we introduce barium through the rectum, and sometimes we introduce air as well, and to distend the colon and to see the hostra and to look at the mucosa. And this is an evacuation film after injection of barium. We instruct the patient to go to the bathroom to evacuate the colon, and we have another film to see the mucosal pattern, and sometimes you can see the appendix in this film, which is clearly demonstrated here. Then some of the malrotations of the colon is that you cannot see the cecum in the right iliac fossa. The cecum may be subhepatic or may be located on the left side of the patient, and this is known as malrotation of the bowel. Then the congenital lesions in the colon include agenesis, atresia, and stenosis, anorectal anomalies, a small left colon syndrome, meconium plug syndrome, and Hirschsprung disease. Then anal atresia means that there is no anal opening, and the colon is atretic, and this is considered either low anomaly or high anomaly, depending on the site of the atresia in relation to the the pubococcygeal line. If the distance between, usually we do lateral film, and it is known as invertogram, because the head of the patient is down and his buttock is up, in order to push the air as far as in the distal part of the colon. Then we put a metallic marker at the supposed site of the anal opening, and we measure the distance between air and the metallic marker, and then this is considered a low anomaly. And here you see this is an example of a low atresia, because the distance is very small between air and the marker. But here is a high anomaly, because a long distance between air and the metallic marker. and this is a high anomaly. This is the invertogram. You see air in the colon. This is the site of the atresia, and you measure between the metallic marker and the air in the colon. This is also a higher anomaly. There is a very big distance between the air in the colon and the metallic marker. And colon atresia means that there is a segment of the colon which is atretic. This will result in distension of the proximal bowel by gases and the collapse of the colon distal to the site of the atresia. Then if you inject barium, then you can see that the colon is small, unused, collapsed, and this is because of atresia of this part of the colon from the middle of the transverse colon and the whole ascending colon. Then this is colonic atresia by plain film. You see distension of the bowel by gases. This may be due to ileal atresia, may be due to meconium ileus, but the presence of this big gas-filled bowel indicates that this may be a part of the colon, and you think that the anomaly may be in the colon. You inject barium, and you got complete obstruction to the flow of barium at the transverse colon, meaning that the proximal part of the colon is atretic, the distal part is collapsed and unused. And this is also colonic atresia. And you see the proximal part of the colon up to the sigmoid region can be seen by barium. The rest of the colon is atretic, and you see here the site of obstruction. Then you came to what's known as small left colon syndrome. A small left colon syndrome means that the segment of the colon, usually the rectosigmoid colon, is small, while the rest of the colon looks within normal or slightly distended. And this small left colon may be attributed to the inspissation of mucus plugs in the left side of the colon. This will result in this part of the colon will be small, as you can see here, while the colon proximal to it will be dilated and distended. Then meconium plug syndrome, it means that there is functional immaturity of the colon in the newborn, and meconium becomes impacted in the colon. Infants will present by distension, delayed passage of meconium, and may have vomiting. Associated conditions include prematurity, maternal diabetes, maternal drug intakes. Then if you look here and you see that the plain film showed distension of the bowel by gases, then the initial X-ray showed moderately distended small bowel, suggestive of lower GI obstruction, and we performed this barium enema, and this barium enema showed that the sigmoid colon is very small and the proximal colon is relatively dilated. And the location of the transition is typical for meconium plug syndrome, or what is known as small left colon syndrome. This small left colon syndrome is suspected to be due to inspissation of mucus plugs into the distal part of the colon, particularly in the sigmoid region. And this disease have to be differentiated from Hirschsprung disease, where the transition zone between the narrowed segment of the colon and the normal colon in Hirschsprung disease is usually located at the rectosigmoid colon, but in the small left colon syndrome, it is present a little bit higher up. The transition zone at the splenic flexure is rare compared to the meconium plug syndrome. Rectal biopsy is considered if constipation and or obstruction persist in order to differentiate between both. Biopsy is not necessary in all cases of meconium plug syndrome. Then meconium ileus is quite different from meconium plug syndrome, because meconium ileus is the impaction of meconium in the terminal ileum, and the whole colon is a small unused colon. But this small left colon syndrome, the meconium is inspeciated in the distal part of the descending colon and the sigmoid colon. This meconium ileus has an intimate relation to cystic fibrosis, and infants may benefit from therapeutic effects of water-soluble enema to push the meconium. And if you see meconium of multiple filling defects in the distal part of the colon, and this is known as meconium plug syndrome or a small left colon syndrome. And Hirschsprung disease is the most common cause of neonatal colonic obstruction, representing about 15 to 20% of cases. And there is a segment of a ganglionosis, and this segment is usually located in the rectosigmoid junction, and males are somewhat more common affected than males. It is almost never, this disease is never seen in premature infants. And here you see by barium enema, there is a narrowed segment at the rectosigmoid junction with distension of most of the colon proximal to this narrowed segment. The short segment is located at the rectosigmoid junction in about 75% of the cases. Whenever we are performing barium enema for suspected Hirschsprung disease, we do not usually proceed to have a full barium study, but we inject barium cautiously through the rectum until we can see the aganglionic segment, and we are able to measure its length. Then we opacify just the normal segment or the distended segment proximal to the aganglionic segment. That is all, and we do not usually continue to perform the or to opacify the whole colon. In about 4% of cases of Hirschsprung, perforation contributes to the increased mortality and morbidity secondary to this disease. And as I have mentioned, you inject barium into the rectum until you can see the narrowed segment, the aganglionic segment, and you opacify a small part of the colon proximal to it, then you stop the examination. Because if you continue to fill the colon with barium, this barium will not be able to, the child will not be able to excrete or make this barium to pass once more outside the colon because of the narrowed segment. Then you may aggravate the patient condition and complicate the status of the patient. This is the rectum, and this is the narrowed segment. This is the sigmoid, which is distended. Then you stop here, not to continue to fill the colon with barium. This is a sort of intestinal obstruction, including the colon and the small bowel. And from the plain film, you cannot say that this is Hirschsprung. And by injecting barium, you can see the narrowed segment with distension of the colon proximal to it, diagnostic of Hirschsprung disease. The acquired lesion in the colon include appendicitis, intussusception, necrotizing enterocolitis, colonic polyps, ulcerative colitis, and Crohn's disease. Appendicitis means that the appendix is obstructed by, let us say, food residue, or commonly what's known as appendicolis, which is a calcified lesion similar to the phlebitis, and this appendicolis will obstruct the neck of the appendix, resulting in accumulation of secretion, distension, then compromise of the blood supply of the wall of the appendix, then inflammation, and may later on perforate. Then ultrasound is very good in this domain. It can demonstrate the appendicolis, which is a calcified lesion within the lumen of the appendix, and any calcified lesion will produce acoustic shadowing similar to the stones. You also see that the wall of the appendix is thickened and edematous. The appendicular lumen is full with fluid. And if you have the CT scan, and you can see that this is the appendix and the wall is thickened and enhanced, you also see some fluid in the around the region of the appendix. And in the lower the section, another section, you can see the calcified appendicolis. Sometimes whenever they are trying to remove the appendix by endoscope, the appendicolis may be missed inside the abdomen, and it will act as a foreign body, and it may result in some suppuration and inflammation and also abscesses in the pelvis. This is very important to be taken out with the appendix. Intussusception can occur in the small bowel and can occur also in the large bowel, and you see the spring coil appearance in the barium study. But ultrasound is very good for confirmation of the diagnosis of intussusception by demonstrating this classic target sign. Sometimes by just air you can see this appearance, which is somewhat diagnostic of an intussusception in the right side of the colon. But then they continue injection of air, aiming to reduce this intussusception. The intussusception can be reduced by barium, can be reduced by air. And then you see that the intussusception is located here. Now it is a little bit down, reaching the iliac crest, and after that it has been relieved by just injection of air. And this is the intussusception, the classic appearance in the right side of the colon with dilated bowel proximal to it. And this is how can the intussusception be reduced by barium. And you inject the barium, this is the intussusception. You continue to inject barium, the intussusception is moving. Then you may got after that full reduction of the intussusception. Then polyps, as I have mentioned in the stomach, are of the juvenile type, and they are usually of benign nature. As you can see here, a juvenile polyp in the colon. Ulcerative colitis is a granulomatous disease of the colon, affects mainly the left side, and it will result in the vibe stem configuration of the colon with loss of ostra. Before this stage, you can see the ulcers as minute buckets were projecting from the wall of the colon, and this is known as, from the radiology point of view, the tram track sign or the double track sign. You see almost two walls of the colon because of the penetrating ulcerations. And in conclusion, the value of the plain X-ray in gastrointestinal imaging of the pediatric patients include the diagnosis of esophageal atresia with or without tracheoesophageal fistula, pyloric atresia, duodenal atresia, single bubble, double bubble, triple bubble, then high and low anal atresia, intestinal obstruction by multiple air fluid levels, necrotizing enterocolitis by air in the wall of the bowel and air in the portal tracts, pneumoperitoneum by the direct copula sign and the regular sign, and meconium peritonitis by the presence of multiple peritoneal calcifications. Then barium is of great value in diagnosis of tracheoesophageal fistula, esophageal stenosis or strictures, whether it is congenital or due to achalasia or due to corrosive or due to post-operative. Then esophageal varices and vascular rings by identification of indentation on the posterior aspect of the esophagus. Also in the diagnosis of gastroesophageal reflux, hiatus hernia gastric volvulus, hypertrophic pyloric stenosis, gastric ulceration, diverticular, gastric pissoirs, and polyps. Also, it is of help in the diagnosis of intestinal malrotation without or with intestinal volvulus, the diagnosis of meconium ileus, inflammatory bowel syndrome, small left colon syndrome or mucus plug syndrome, Hirschsprung disease, intussusception, and the colonic polyps. Barium has a therapeutic effect in patients with meconium ileus for liquefaction of inspissated meconium, and in cases of intussusception, it can help in reduction of the intussusception. Ultrasound is the modality of choice for diagnosis of congenital hypertrophic pyloric stenosis, necrotizing enterocolitis, acute appendicitis, and small and large bowel intussusception. Thank you very much. الحمد لله رب العالمين.